So, each year in June, we strive to focus on topics surrounding trauma and the military, with it being Post-Traumatic Stress Disorder Awareness Month. But we really want more than just awareness. We want to look at solutions. So what and how can people tackle these overwhelming symptoms to make life and relationships a little bit more bearable for some individuals? It can be a really challenging condition that people experience. So that's why I'm really thankful to have Dr. Johnson, a board certified psychiatrist who serves as HopeWay's Director of Veteran Services. He has expertise in, I'm gonna stop sharing. And Dr. Johnson, you can start sharing if you'd like. There we go. Back to it. He has expertise in PTSD or post-traumatic stress disorder and TBI or traumatic brain injury, men's mental health, military and veteran mental health, the care of patients with complex co-occurring medical and psychiatric disorders, and psychotherapy. Previously, he has worked with patients at the Durham VA or Veterans Affairs, at Iraq and Afghanistan Combat Veteran Clinic. He is currently an assistant consulting professor of psychiatry at Duke University School of Medicine, where he supervises Duke trainees. In addition to HopeWay and Duke, Dr. Johnson currently serves in the U.S. Army Reserve, has deployed in support of several operations, and is interested in military medicine. He continues to publish in academic journals and is regularly invited speaker at conferences on the topic of psychiatric care for the combat veteran. We also have with us Karen Ortiz, and she is the outreach specialist at HopeWay, and she'll tell you a little bit more about her role as well. So without further ado, I'm going to turn it over. Thank you guys so much for having us today, or being with us today.
Thank you, Lauren. Thanks for having us. Before I get started with the presentation about PTSD, I'm going to turn it over to Karen to let her introduce herself and to tell you all a little bit about HopeWay. So Karen.
Thank you, Dr. Johnson. So nice to meet all of you from afar, from all over the country. I love it. My name is Karen Ortiz, and I'm a clinical outreach specialist at HopeWay. And really wanted to introduce myself and our overall program briefly to really give a foundation to what Dr. Johnson will talk about. Grew up on Air Force bases. So my father served in the Air Force, and this particular program and serving veterans is very close to my heart. I am basically from New Mexico, but have lived all over the country and have been living here in Charlotte, North Carolina for about 12 years. To tell you a little bit about HopeWay, HopeWay is a nonprofit mental health facility, and we serve adults 18 and up and have been in existence for over 5 years. We are joint commissioned, and we're also a behavioral health home, which some of you might be aware of this in your professional setting, but that is really a certificate or distinction that speaks to the medical and the psychiatric care for an individual, the integration of that. So at HopeWay, we have a very holistic, integrated, evidence-based approach to the treatment of mental health. We serve people with depression, anxiety, bipolar disorder, trauma, schizophrenia, and more, a lot of co-occurring disorders, and also co-occurring substance use disorders. We're a vision of a couple, Bill and Betsy Blue, who had a family member go through a mental health crisis and had to leave the state for treatment. And they really came back to North Carolina and said, what can we do for this state and this area of the country and beyond? And so they've come up with this model that we are now implementing. They traveled the country looking for best practices, and then thus HopeWay was born. We have 7 psychiatrists on our staff. So we take mental health first and foremost very seriously. We have the full continuum of care for people. We have residential treatment, 36 beds, 36 private rooms with private bathrooms. Really a place for people to go between the hospital and the home for treatment. And that can look either way. That can be to try to avoid the hospital setting for people, or if they've stabilized after treatment in an inpatient unit, then they can step down to HopeWay to continue their recovery. We also have a day program, Monday through Friday. And we also have intensive outpatient programming, both in person and also virtual for those within the North Carolina borders. So that, all that being said, I wanted to just express that it's voluntary, and our leadership has been from the get-go very committed to serving veterans. And so after we were opened a few years, we started to pursue how can we serve them, and we went through a drastic fundraising effort because, as I mentioned, we are a nonprofit, and we have developed under Dr. Johnson's expertise our PTSD intensive program. So I'm going to put my information in the chat. I am your first point of contact if you like. I am happy to talk to individuals or families who might need services, or clinicians, or present more to your team. Just to let you know, we're here as a resource for you. We have people coming from all over the country for treatment with us, 37 different states, Canada, and the Philippines. So what we do here is very unique and special, and I think something people, frankly, they deserve. So I'll put my information in there. As an aside, we are a network with most major insurance companies and also a VA community care provider. So I'll let Dr. Johnson talk more about PTSD and how that pertains to also our clients that we treat at HopeWay.
Awesome. Thank you, Karen. So if anybody out there has any veterans in particular, or non-veteran adults who would benefit from treatment for PTSD, depression, just general mental illness, Karen is a good contact to try to help get those people in to HopeWay. So thank you all for having us here today and for the opportunity to speak. As mentioned in my bio, I'm a psychiatrist. I've worked at the VA, now work at HopeWay. I'm also in the Army Reserves, and really I've developed my interest in how can we do better to take care of combat veterans, and so that includes traumatic brain injury. But today I'm going to talk about post-traumatic stress disorder, or PTSD. And as Lauren mentioned, any questions people have during the talk, just fire away with them throughout the talk. We're going to try to monitor the chat box, and I'd like to answer them as we go, because a lot of times that leads to good discussion. If we were in person, you'd just be raising your hands throughout the talk. It's totally fine with me. It's not going to get me off track or anything. So definitely do that. All right, let's see. So I always mention like disclosures. I'm not, the opinions I present are my own, although throughout the talk, I do as best I can to follow the evidence-based, like what is the scientific literature support that has been proven to help people with PTSD. But as I mentioned, I do work for HopeWay and the Department of Defense, and the things I'm saying don't reflect any positions by them. So this is just to get started. I heard a lot of the people lived in North Carolina, it sounded like, or a few from Virginia, and then some other people from other parts of the country. But this is a neat slide that a former colleague and mentor of mine, Dr. Capehart, who works at Duke in the Durham VA, created a few years ago, that I just think is interesting, and it reveals the enormous military presence in our area if you live in the North Carolina, Virginia, South Carolina area. Dr. Capehart had estimated that about 20% of U.S. military assets are within a 5-hour drive of, this was, he's at Duke, so a 5-hour drive of the Durham area. And you can see by this picture, there are an enormous number of military bases and units and installations all the way up from Washington, D.C., down to, of course, Fort Bragg here in North Carolina, which is the largest military installation in the world by population of any country. And then down in South Carolina, I know a few people over in Texas. Y'all in Texas, you have an enormous military population as well. And so really what I'm trying to highlight here is that particularly since traumatic brain injury and PTSD are unfortunately common in veterans and military members. We're going to see them a lot. And obviously this group on this call sees a lot of TBI. That's the whole purpose of the organization. But in addition, because they're co-occurring in veterans, you're going to see a lot of PTSD. And so I think it's important to understand how do we take care of people with PTSD, especially veterans. So let's see if there's a question. Oh, that's Karen's information. All right. So the overview of today's talk. So I'm going to use a case example. So a hypothetical, clinical scenario to try to help think about PTSD. And what I want you to do is at the end of the talk to be able to pick what is the most evidence-based recommendation for this potential patient. Then we're going to talk about combat PTSD in particular, then talk about how do you make a diagnosis of PTSD. Then I'm going to talk in depth about PTSD treatment, and then summarize with reviewing the case example again. All right. So the case example. So this would be, let's assume that you're working in like a hospital setting. But really, you could see this type of person really anywhere. So a 33-year-old male with no medical or psychiatric history presented to your civilian hospital for an emergent appendix removal, and you were asked to see them to help with irritability. The team said that the patient has been very irritable, asking to leave against medical advice frequently, and the team wants your help to help with his irritability. So when you go to talk to the patient, he says he generally doesn't like people in authority who have too much power. He got into an argument with a nurse over being able to use his cell phone, gets into arguments with the medical team, the doctors pretty frequently. He eventually relates these ideas back to authority figures he had when he was a combat medic in Iraq in 2005 and again in 2008. During that time, he was sent out on a lot of missions by, in his words, quote, shitbag commanders who always stayed back on the base. He felt like the leadership didn't care about him. He felt betrayed. He just has this general anger, irritability regularly. When he was deployed, he took incoming fire lots of times. He lost several friends and still has vivid flashbacks about trying to save their lives. He has this general anger and resentment towards Army leadership that he feels like made it hard for him to trust people, people who he says, quote, think they're better than me or know more than me. And he thinks that this mistrust has spilled into his interactions with the medical team in the hospital. So he generally avoids medical care because it reminds him of his time as a combat medic. And he's been having nightmares since he's been admitted to the hospital. He generally can't sleep that well. He wakes up frequently. He says he's always on alert. He has nightmares a few times a week. He generally avoids crowded places. And so he pretty much just isolates at home. So he really doesn't like being in the hospital. He's had sort of a loss of interest in things ever since that deployment. He feels detached from his family. No suicidal thoughts, no changes in appetite, energy, hopelessness, no psychotic symptoms. Smokes daily, but no other drug use, no previous suicide attempts. He will sometimes get angry at people and want to punch them, but he denies any specific people he wants to hurt. He used to be a Christian, but he's not sure if he believes in God anymore. No other medical problems. When you go to talk to him and you're trying to sort of gauge how you can be helpful, he says he's not really interested in talk therapy because he says, quote, that's all bullshit. But he is maybe interested in medicines and he might be willing to follow up with mental health occasionally. And so after, many of you maybe already know some ideas of ways to help this person, but after the talk in particular, you should have some ideas about evidence-based, proven ways to help him and things to offer him. All right, so when we're talking about combat PTSD, the term post-traumatic stress disorder started in DSM, I think it was DSM-3 in 1980 was when it was first codified as an official diagnosis by the APA's Diagnostic and Statistic Manual. But PTSD, the disorder, has been around way longer than that. It's been around all of human history. So ever since humans have been doing traumatic things and fighting each other and getting into warfare and conflict, we've had PTSD. And so that, if you know anything about humans, that's all of human history. So we've always been fighting and having conflict. And so just a picture here of the Aeneid, which some people might remember from high school or reading back in the day. And so the Aeneid was written several thousand years ago. And some of the characters in it will display features that would be consistent with what we call PTSD today. And so again, the disorder's been around forever. We just have recently come up with a term for what we call it. And the picture to the right is what was called the 1,000-yard stare, or used to be called shell shock. There were a lot of symptoms that overlap in World War II. You read descriptions of soldiers after the Civil War that sound exactly like people that we know today that we would diagnose with PTSD. And so unfortunately, it's been around forever. And also, unfortunately, we've made a lot of progress in ways to treat PTSD, but we unfortunately still have a long way to go. Many of the treatments I'm going to talk about today are not great, unfortunately. But they can be effective, and so I think it's important to know what they are. So in terms of combat PTSD, so military veterans, so there's more, this number is actually outdated now, but more than 2.7 million veterans from the Iraq, Afghanistan wars. And it's the estimates of PTSD prevalence in military members is variable. Most of the estimates that I've seen range up to around like 20% of military veterans will go on to develop PTSD. This says here again, about 23% of the Iraq, Afghanistan veterans who use the VA have PTSD. But the big thing that's important to know is that there is a direct correlation between combat exposure and development of PTSD. So combat exposure, what does that mean? That means being deployed into a setting where you took incoming fire, you shot at other people, you felt like your life was in danger. That's what's considered combat exposure. And so having combat exposure significantly increases your risk of developing PTSD, which makes sense when, as we talk about in a minute, what it takes to develop PTSD, that it makes sense. And so it's important, if you're talking to veterans and you want to try to screen for could they have PTSD, and it's important to understand what the person's job was in the military. So for example, I have deployed to a combat zone, but I have not had combat exposure. So I was in Iraq, and I was in it's considered a combat zone, but I never felt like my life was in danger during that time. So I would not characterize myself as having combat exposure. So that would not necessarily increase my risk for developing PTSD. But and my job in the military is a psychiatrist, so a medical doctor. So, but if you meet veterans, particularly veterans over the past 20 years who have these jobs listed here, then I think you should try to screen them for PTSD and combat exposure, because these are the jobs in the military that have had the most combat exposure, particularly in the post 9/11 conflicts, but really in any military conflict. And so an infantryman, that's a person whose job is to go out and win a war, so to go out and fight. So obviously they have combat exposure. And I won't read them all, but these other jobs. So a combat medic, that's like our hypothetical patient in the case scenario. He was a combat medic. They have lots of combat exposure. And so it's important just to explore a little bit what the person's job was in the military, because it can give you very useful information. All right, so how do we make a PTSD diagnosis? So the most updated diagnostic criteria for PTSD come from the DSM-5. That's the most up-to-date American Psychiatric Association handbook, basically, that lists how you make various psychiatric diagnoses. So the first criteria for developing post-traumatic stress disorder is to have had something traumatic. So it's in the name, PTSD. So somebody can't come and say, oh, I've got PTSD, I've got all these symptoms, but they've never had a trauma or anything traumatic, then they do not have PTSD. So post-traumatic stress disorder the person has to have experienced a trauma. Now, the word trauma gets used very loosely and very liberally by people, especially in mental health settings, where they'll say, I was traumatized by this, or this was a trauma. And I really try to use it carefully, because when we're talking about PTSD, technically trauma has to be something where your life was in danger, or you were threatened by serious sexual violence or serious injury. So someone comes to me and tells me, well, my dad yelled at me and that was traumatic. That does not count as trauma and should not lead to the development of PTSD, because they did not feel like their life was in danger. They did not have actual threatened violence. So this is an important point about PTSD. When we use the term trauma, I really try to narrow it down and use it only for these types of events. Otherwise, I call the events like unfortunate events or something that you felt was, destabilizing, or it was concerning or anxiety producing. But I try to not call it trauma, because then I think it blows up the idea that lots of people are being traumatized, when really it's a very specific, subset of people that have had these types of events. So some examples of serious trauma that could lead to PTSD are directly witnessing the event, and experiencing it, but also if you learned about the event to a close family member or friend, that can lead to PTSD. And then even like repeated exposure to things. So this would be things like first responders who frequently see death. So like a police officer who sees people getting shot frequently, that can lead to the development of PTSD. So if you're screening for PTSD and if the person has had a traumatic event like that, then you move on to the next criteria. So really with any psychiatric disorder, you can basically go down a checklist of symptoms, and if they check one off, then you move to the next one. And if they don't check one off, then you can just stop screening for it. So if they check off that they have a trauma, then you move to these criteria. And there are basically 4 big areas of what we call symptom clusters. So the first symptom cluster we call the intrusive symptoms. So these are things that people think of commonly. The 2 most common are nightmares and flashbacks. So flashbacks are where you feel like you're taken back into the moment. So like somebody who suddenly thinks they're back in Iraq and they're on guard and they've dropped behind like a car or something, that could be considered a flashback. But dissociation is also included in here. And so you just need one of those features for more than a month. The next one, if they have that, the next one is avoidance. So what avoidance it means is that the person actively avoids reminders of whatever the traumatic event was. So for example, not related to combat vets, but if you got into a car accident and then from then on you avoided the area that you drove where you had the car accident, that counts as avoidance. Or for combat vets, if they avoid watching things about war or they avoid talking about it. So your grandparents who refused to ever talk about World War II, that counts as avoidance. And so if they have these other features of PTSD, they might have PTSD. So if they have avoidance, you move to the next one. So the next one are negative cognitions and negative mood. So these are things like a constant anger or irritability, depression, or feeling detached from your family. So I have a lot of combat vets who will describe, I just don't have any interest in being with my family anymore. I don't find joy in that. These 2 or more of these types of symptoms are high anxiety. These would count for the 3rd piece of the diagnostic criteria. And the 4th piece is arousal and reactivity changes. So some things that fall under this are the hypervigilance that people may think of. So the constantly like looking over your shoulder, constantly being on edge, easily startled, needing to sit with your back to a wall, for example, to scan the room, but also sleep problems. So not being able to sleep very well would fall under this. Dangerous and reckless behavior can commonly happen. That falls under this category. And so 2 or more of these symptoms would fall under this sub piece. And by the way, I'm not listing every possible symptom, but to do that, you can just Google and search for PTSD diagnostic criteria. There's actually 20 different criteria that would be under each of these. And if you ever don't want to remember that, you could give people, there's a screening tool called the PCL5. That's a great screening tool. That's a checklist questionnaire that the patient can fill out themselves. And if they have a score above 33, it could be considered PTSD. So in general, you want these symptoms, if they have all of these, to last more than a month. So if they have them and it's only been 2 weeks since the trauma, that actually could be normal. That could be what we call an acute stress disorder, which should go away with time. So really, it's if it doesn't go away with time, it could be PTSD. All right, so let's see if there's a question. Oh, the PCL5, good, thank you, Lauren. Lauren sent into the chat the PCL5, which is a great assessment tool. All right. So moral injury. So when we think about PTSD, a really interesting and difficult to treat piece of PTSD is something called moral injury, which point, usually, I'm sorry it's not more interactive. Usually I'd have people interact and tell me what they think it is, but you can't really do that in this setting. So I'm sorry that I'm just basically giving you all the answers. But a moral injury is an experience in which an individual perpetrates, fails to prevent, or learns about things that transgress moral beliefs. So, for example, in combat vets, you kill, maybe let's say you kill a child. That could cause, and often does cause, profound moral injury for people. So if you've grown up your whole life believing, as most good people do, that killing people is wrong, especially killing children, then when you kill a child, that really is going to stick with you potentially. And we call that phenomenon moral injury. So it's almost like you have a scab in your soul or something to that effect. So you carry this burden with you that can lead to frequent feelings of guilt or like a failure and shame that can fall back under guilt. And shame often presents under this, the negative cognitions and mood piece of the PTSD diagnosis. And so other common examples of moral injury are many combat vets often mistrust the government or mistrust the military. Leadership, like our example, can be very common for people to say, I don't vote anymore, or I don't trust the government. That can often be a result of moral injury where they feel betrayed. In addition to the probably more popularly known kind of examples of people who feel like they shouldn't have killed a certain person, or survivor guilt can fall under a level of moral injury. Unfortunately, for moral injury specifically, we don't have any really proven ways to treat it, but the therapies that I'm going to talk about generally can help it. It's an area that's being studied a lot. There's a guy, Dr. Harold Koenig at Duke, who really is a world expert in moral injury, and he's doing a lot of research into studying how we can do more to treat this. All right, so what are the evidence-based treatments for PTSD? The first line primary evidence-based therapy for PTSD. Actually, I do want to go back because I know we still have a pretty good amount of time. In PTSD, as many of y'all probably see, PTSD overlaps quite commonly with traumatic brain injury. And so in combat veterans, it's very common to have both of those diagnoses. And unfortunately, it can often be difficult to determine, do these symptoms that they're having of irritability, for example, memory loss, are they coming from TBI or are they coming from PTSD? Because PTSD can cause many of the same problems of things like memory problems, sleep disturbance, irritability or mood problems. These are all things that can come from traumatic brain injury or can come from PTSD. And there's really no definitive way to tease apart. I mean, you could do like neuropsychological testing that maybe could help tell, does this come more from one or the other, but it's really difficult. And so in many ways, what I do is, some ways it doesn't matter, like some of the treatments could be similar. And so you might try to do a primary treatment for the PTSD. And if it gets better, then perhaps it's from the PTSD. Or if, for example, with memory problems, sometimes we can use stimulants like Ritalin in people with traumatic brain injury, and maybe it gets better, then that probably was more likely a result of the traumatic brain injury. So sometimes when we do a treatment, that gives us more information that can help us determine, what was primarily driving it. But frankly, when you're actually working with patients, in my experience, it doesn't necessarily matter that much, like which is causing it. If they have both, you're going to try to go down the evidence-based path to help them. They're very similar anyway. And unfortunately, they overlap because, often the things that cause the traumatic brain injury, it has the word trauma in it also, like PTSD, led to PTSD. And so like a roadside bomb, for example, caused a TBI and also created PTSD. And so not only do the symptoms down the road overlap, but the originating factor of the trauma happened at the same time. So the disorder started at the same time. And so those are reasons why it can overlap. And I think we don't understand it well enough. There is no, unless it's a severe TBI, there wouldn't be any specific head imaging or lab tests that would prove that this is TBI versus PTSD in terms of causing the symptoms you're seeing. Okay, so in terms of treatment for PTSD, so the primary treatment, if you have anyone in front of you who says, I have PTSD, or you think they have PTSD, and they ask you, hey, even if you're not a clinician, if they ask you, what can I do to get better from this PTSD? Well, the primary treatment that has been the most proven to help with PTSD is psychotherapy. So better than any medicines. And so your answer should never be, well, the best thing to do is take a pill. That's the best way to get better from PTSD, because that's not true. That's not consistent with the medical evidence. Medical research supports the idea that people generally get better more from psychotherapy than from medicines. But the medicines can be helpful. So I'm not totally discounting them, but I just want you to always be thinking that the person with PTSD, if they really want to get the most benefit, should be trying to get into some type of psychotherapy or counseling. And so pretty much every major organization, so the VA, the Department of Defense, the APA, the ISTSS, that's the big international PTSD focused clinical organization. So all of them recommend psychotherapy as the first line option for getting better if you have PTSD. The VA in particular typically recommends what are called the evidence-based trauma-focused psychotherapies. So what this means is these are typically therapies where you are focused on the traumatic event. So it typically involves you having to talk about the trauma, process through the trauma. And by evidence-based, they just mean these are therapies that have been studied and proven in research studies to show benefit in people with PTSD. Now, most of these therapies are also what we call manualized therapies, which means that they follow a protocol. So for example, with cognitive processing therapy, you typically do 12 to 16 sessions where there's a book. I think I have it here. There's a book, a handbook, Cognitive Processing Therapy for PTSD, that you pretty much follow the handbook. And it's a rigorous, like regimented structure for doing the therapy. So that's what a manualized therapy is. That's different than like sometimes people are doing more like open-ended therapies where, you know, there is no set time frame. Like you could do therapy for 6 years, for example, and you meet weekly, and maybe it's not as focused on like a regimented approach like that would be. So the VA and the DoD in particular tends to recommend more of those manualized types of therapies. And these are the ones that have the strongest evidence that are listed here. I'll briefly go through each of these and sort of what they are. So in general, most of the evidence points towards therapies that involve the person exposing themselves back to the traumatic event so that they can process through it and reduce their response to it, or questioning and reframing their thoughts and their guilt around the trauma. So most of the therapies specifically have to do with that. These are the therapies that have been proven to help. So the first one is exposure therapy. So the general idea of that is you expose yourself to the trauma enough times until your response reduces. So for example, if you were in Iraq and you had lots of explosions happening, and now every time you're around a car that backfires or fireworks, you have to go inside and hide and your anxiety goes up. This therapy would have you gradually be around fireworks enough until the response goes away. So it's really like behavioral conditioning, which is like a dog, you know, drooling when you give them a treat. It's the same kind of thing. We can extinguish that behavior with enough exposure. So that's one type of therapy. Let's see if there's a question in the chat. Are those manuals easy to get and use? Generally, I think so. So the CPT manual that I have, you can buy that on Amazon. I think that's where I got it from. And if you're trained in therapy, my opinion of it is that you can read the book and sort of know how to use it generally. Technically, to be certified as a CPT provider, I think you have to have done the CPT course through the people who created CPT. But I mean, if you're out there in the world seeing people, you get this book and you're trained in basic cognitive behavioral therapy, I think it makes sense and you could do it. Now, some of the other therapies like EMDR, I really think require specific training. But yes, generally you can get these handbooks. Has art therapy been studied yet? I don't know much about art therapy actually in terms of PTSD. We do offer art therapy here at HopeWay. That's one of our therapies that actually gets the most positive feedback and has won several awards. And so just based on my experience with veterans, I think they find it very helpful, but I'm not sure if it's been studied in research studies. All right, so that was exposure therapy. The next one is cognitive processing therapy. That's the handbook I just showed you. That's basically like CBT. And so it involves doing a lot of homework. So you're giving constant homework assignments to the person. and they're basically challenging some of their thoughts. So for example, if they have the thought that they should have done more to save their buddy in Iraq, typically that's a distorted thought that's not based in reality. Typically, when you really look at the evidence, most people have done everything they could have done, and there was nothing they could have done to change things. And basically, this therapy helps the people learn to realize that, which then diminishes the PTSD symptoms. EMDR is a pretty popular therapy that involves talking about the traumatic event as you move your eyes back and forth, or you touch like paddles with your hands back and forth. Not really sure how it works, but it probably has to do with exposure as well, that you're basically re-exposing yourself to the trauma enough times until it doesn't bother you anymore. And that's one key of why the avoidance piece of PTSD is part of the diagnosis, because it's problematic that you avoid things. We want people to be living their lives. If you're a combat vet and every time a war movie comes on, you have to leave the room, that's not functional. You should be able to sit there and watch it. You shouldn't have your life totally disrupted by what happened. And so a big piece of the therapy is to reduce the avoidance that people have. Or for the first example of driving a car, realistically, you're going to have to drive down that road you wrecked on at some point. And so it's not productive to have you continue avoiding it. So other therapies that have been proven are CBT for PTSD. So that's a common type of therapy that again involves like challenging your thoughts and changing your behaviors by doing homework assignments. Some less commonly available therapies are narrative exposure therapy and written exposure therapy. Both of these involve either writing out the trauma again to re-expose yourself to it, or talking about it enough times until it doesn't bother you. Brief eclectic psychotherapy is a type of therapy that just involves sort of a combination of CBT and psychodynamic therapy, where you're challenging your thoughts, but also diving into a bit of like what your relationships were. And so all of these these are the ones that have the most evidence in people with PTSD. But I really will add to y'all that, when I have looked at the research literature and when I've actually seen patients myself, unfortunately, many patients still drop out of these therapies and really don't want to talk about it. Or they just don't work for some people. The therapies are not like a smoking gun that definitively 100% treats everybody. It's not like let's say if you have a broken ankle and we know with 100% certainty this is the procedure that's going to fix you. These therapies are not that clear cut, in my opinion. So if you have a person who really doesn't want to do these therapies, but maybe is more interested in doing like psychodynamic therapy that's listed at the bottom, then I think getting them into any kind of therapy is better than nothing. And so I think your primary takeaway you should have is just to get this person into any kind of therapy is a good place to start, because the other therapies listed at the bottom also might be helpful. In fact, psychodynamic psychotherapy, which is more of like Freudian therapy, where you like tell me about your mother and you analyze your dreams and that kind of therapy, that actually is probably going to be added to the next round of the VA and the DoD evidence-based therapies for PTSD, according to somebody I know at the VA. And so, it's a great therapy to get people in as well. But that's actually a therapy that I primarily do with my, non-veteran patients. So, anyway, that's a takeaway for the therapy piece. Let's see, any research on brain spotting with PTSD? I don't know much about brain spotting, so I can't comment on that, but I have been asked that from other people. Please feel free to comment on there. Tell us a little more about, what that is and what your experience with it is. And then we'll pay attention if he does that. All right, let's see. So in addition to the therapies, so if the person's going to do therapy, or let's say like in our example, the person says, I'm not doing therapy. They don't want to do therapy, or as we all know, it's often very difficult to find a therapist or to make the time to do therapy. I mean, it's usually a minimum once a week for several months. It's a big time commitment for people who are busy and have other things. And so medicines are an option as well, and medicines can help people with PTSD. And in fact, despite the fact that I said at the beginning that therapy for now has actually been shown to most likely be more beneficial than medicines, there are actually a couple of recent studies that actually question that and showed that some of the medicines can be just as helpful as the therapies. And so I encourage people to, if the person is interested in medicines or has a doctor that's trying to prescribe them something, to encourage the person to take those, because they definitely help people. Let's see what the chat said. Karen, you are on mute and we could not hear you. Somebody said, did Karen say something?
It's all good. I just wanted to make sure that you got that brain spotting question.
Oh, good. But that's the second time I've been asked about brain spotting in the past couple of weeks. So I need to learn more about that. All righty. I guess I would say it's not a common thing among the worlds that I've interacted in the healthcare systems. It's not something common that I've seen. Does not recommend any outdoor adventure therapies. So Carol Kirkland asked, the VA still does not recommend any outdoor therapies. So first of all, I should comment, I'm not a decision maker in the VA making these guidelines. And these guidelines do not say that you should not be doing outdoor adventure therapy. What these guidelines say is that these are the therapies that have been proven the most in what are called randomized controlled trials. But it doesn't mean that lots of other things don't help people. And that's my approach with veterans. So if I have a vet that comes to me and tells me, like, doc, the only thing that helps me is to get out and to ride my horse or to go shoot my gun, I'm not going to tell them, well, there is no evidence in the medical literature that says that that's going to help you, because that's ridiculous. And if the person in front of you tells you that this is what helps them, unless it's something illegal or something you can't support, we want to try to get that person to do that. And so I think with outdoor adventure therapies, I'm not aware of the research on that. So if you are, please, put that in there if you know. But I think what the VA will be saying is that we do not have enough randomized placebo-controlled trials that show proof of outdoor adventure therapy working in people with PTSD to support them. So, I'm a medical doctor. And so in medicine, everything we try to do is based off of research studies. So again, like a heart doctor, they're not just going to give you a treatment for the heart. They're going to make sure that it's proven first. And so these recommendations are based on what has been proven. But many of these therapies don't work. And so we need to research more of these things more. And so that's what I would say regarding that, is that no one at the VA is saying that you should not be doing outdoor adventure therapies. They're just saying that there's not enough research evidence that shows its benefit. Feel free to ask back if that didn't clarify. Again, I know it's a little time delay with the question box, and I'll keep talking as we go. So for the medicines, so if the person, I don't know how many people in here prescribe medicines, but just to give you a general overview of medicines as options. So these are the 4 medicines that have been, again, proven the most to help in people with PTSD. And I guess maybe just because, I don't know how familiar people are with like research studies. So I mentioned a minute ago, a randomized controlled trial. People, you may have heard of that term. So if you already know what it is, I'm sorry, but I'm not fully sure who everybody is on the talk and what your backgrounds are. But a randomized controlled trial is basically where you take 2 groups of people, you give one person one group one treatment, you give another group another treatment, you see how they go, and then you see if it had benefit with the treatment versus this non-treatment. That's the gold standard in medical care. So for example, in the COVID-19 vaccinations recently, so to make it something relevant, randomized controlled trials were done on, for example, the Pfizer vaccine. So an enormous group of people got the COVID-19 Pfizer vaccine, an enormous group of people got placebo, which is basically like a sugar pill. And if these people with the Pfizer shot had a big benefit, then that shows evidence that it worked. That's what I'm referencing when I keep referencing evidence-based treatments. These types of treatments, like these 4 medicines, have been proven in those types of studies, randomized controlled trials, to show benefit. So these are the 4 meds. The common names for these medicines are Zoloft is sertraline, paroxetine is Paxil, fluoxetine is Prozac, and venlafaxine is Effexor. So Zoloft, Prozac, Paxil, and Effexor. Those are the 4 medicines that have the most evidence showing they benefit in people with PTSD. So really, if you're trying to have an evidence-based approach, these would be the 4 medicines you'd be trying to be starting on for somebody who has PTSD. There's a question. It says, from trainings with TBI and PTSD, it's difficult to have research-based studies because the brain is affected differently in each person. So it's hard to find control groups. Totally. Yep. Or to isolate what made the changes. Yes. And that is probably why many of these treatments are not great. Like it can be very difficult. They're not, our treatments, including these evidence-based treatments, are not as effective as other types of medical treatments, unfortunately, because it's a complex patient population that I know y'all see every day if you're working with people with TBI. All right, and so my approach is always to try as best as I can to follow the evidence-based recommendations, but also being very humble and very open to other ideas for helping folks. All right, let's see. So other ideas for medicine. So really, when you get beyond those 4 medicines, it's becoming a little bit more experimental. There's not as much evidence for really any other medicines in people with PTSD, but they probably do work and do help, and they do help people a lot. I see it every day. I won't go over these detailed medicines. So just another class of medicines that can be very helpful in people with PTSD are what are called the antipsychotics. So those are things like these 3 medicines listed here are Zyprexa, Risperdal, Seroquel are the trade names for them. You may see those in people with TBI as well. They're commonly used in TBI. They can be helpful to reduce like the hypervigilance or easily startled, or some of like the nightmares sometimes, or agitation. So those could be useful medicines. If you have people with TBI or PTSD who can't sleep, if they're combat vets, really one of the first things you want to do is make sure they don't have sleep apnea. So for reasons that we don't know yet, people with combat veterans have higher rates of sleep apnea than non-veterans. And so sleep apnea is a disorder that is easily treatable, and that could be contributing to a lot of the symptoms that we described. And so you don't want to miss that. Besides that, if they're continuing to struggle with sleep, CBTI is a type of therapy for sleep that really is the primary recommended treatment for sleep disorders generally. So you try to get the person to do some type of CBTI. If that doesn't work, some other medicines that can be helpful, or some of these medicines listed here. I won't read them all, but Lunesta actually interestingly has a small study showing benefit in PTSD in addition to just helping people sleep. So that's a good one to use sometimes. All right. So prazosin is another common medicine that's used. It can basically help reduce nightmares, and it's a great medicine. There have been some studies recently that maybe showed no benefit, but really it's the best medicine we have for nightmares. And so if you have a person who's having nightmares and they're interested in a medicine to reduce it, prazosin is the first option to go to. There's also a type of therapy that's listed here called image rehearsal therapy that has the most evidence. I think it's hard to find that therapy, but if you can find it, then that actually probably is the best recommendation. All right, and then just some other medicines listed down here, things you could use. So one other important thing to go over is benzodiazepines. So benzodiazepines are the class of medicines that include Ativan, Valium, Klonopin, Xanax are the 4 most common ones. Very commonly prescribed medicine in people with anxiety disorders. Hopefully not commonly prescribed in people with traumatic brain injuries, but I don't know what you're seeing out there. Please tell me if y'all have a lot of people who are on benzos who have TBIs. Let me know in the chat box. But in general, you want to avoid benzodiazepines in people with PTSD for a whole bunch of reasons. These are the 6 reasons why. So first, benzos basically work like alcohol, and so any of us who've ever been drunk before, if you've ever been intoxicated or seen people who have, that alcohol is disinhibiting. So it makes you make decisions that you otherwise usually wouldn't do. And so benzodiazepines do the same thing. They work just like alcohol. Which, to the second point, in people with traumatic brain injury who already might be disinhibited because of like a frontal lobe injury or something, benzos make that worse. Also, the third reason, they're dependent, so you get addicted to them. Fourth, you could have long-term cognitive problems. So they're sedative hypnotics, so they generally slow your brain down. And so somebody who maybe already has problems with memory or focus or concentration, you're now putting them basically on alcohol. And so you don't want to do that. You want them to be able to think clearly. But the last 2 pieces are actually big ones as well. And so there's actually some evidence that benzos can interfere with the person recovering from PTSD, especially if they're doing one of the therapies that I talked about. And the 6th reason is because the studies that have been done have shown no benefit. And so when a person comes to me telling me I got to continue this benzo, I list these 6 reasons for why I basically would be doing almost negligence if I continued prescribing them benzodiazepines. And so you really try to get these people off of benzodiazepines if you can. And so if you have people who are on benzos, especially if you see any of these problems, if you're their doctor or not, communicating with their doctor about, hey, is there any ways we can get this person off, or what are you thinking? Ask the doctor what their thinking is for why they're on it, because there are some people who, I do have people who are on benzos, and I usually try to have like well thought out reasons for why they are on them. All right, so the last piece is just a little bit about maybe future therapies, which I guess I potentially should add brain spotting to this when I learn more about it. But, what are some new ideas that really haven't been definitively proven yet, but are things that I think are very interesting? So this is a picture of a good book I think I have on my bookshelf here too that I'd recommend to people if you're interested. That's basically about psychedelics. So psychedelics are they're actually not new. They've been around for all of human history, but it's a recently popular idea in psychiatry where you use things like MDMA or ecstasy or hallucinogenic mushrooms. So things that could cause hallucinations or those kinds of typically illegal drugs to help people get better. And the first one, so very interesting studies about basically giving people ecstasy while they also do some of these therapies I talked about that showed benefit. Very interesting. So when you think what ecstasy is, ecstasy also called MDMA, it's an empathogen. So what that means is it increases your ability to feel empathy, so to feel for people. And in people with moral injury, where they're constantly beating themselves up and blaming themselves for things, feeling guilt, taking ecstasy basically helps relieve that burden for them. And so they feel more accepting of the things that happen. So I think that's a very interesting new approach that really is just going to grow in evidence coming forward. Now, the difficulties with it are these drugs are still illegal. So you can't just go prescribe somebody ecstasy or shrooms to get better. So it's going to need more research, and you have to be practicing in an approved research setting to use them. Ketamine infusions, there's also some interesting recent evidence that maybe that helps in people with PTSD. The last one that many of y'all may have heard about is stellate ganglion blocks. I hear asked about this the most. So that's a treatment where basically you go into your stellate ganglion in your neck here and inject it with something. I don't do it myself. And it potentially reduces like what's called your adrenaline response or your sympathetic nervous response, which is basically your fight or flight response. It reduces that. And so these studies, and many of them have been done in active duty in the Army, actually at Fort Bragg, I think shows a lot of potential for getting people better. And that can be hard to find it. Most people who do stellate ganglion block do it for chronic pain and other things now. But if you can find somebody who does stellate ganglion block and will do it for somebody with PTSD, and the person with PTSD has tried and failed other things, that's when I would think about this as an option. I would not go directly to this. I would want to make sure they've tried and failed various therapies and medicines before trying to do this, but it is another potentially interesting treatment. So back to the case example, just to highlight, I highlighted here in red just some of the things that we've talked about today. So some of the features of the diagnosis, so the irritability, the being a combat medic in Iraq means he had a trauma exposure. In fact, it says later that he had a trauma exposure. He took incoming fire. The vivid flashbacks, that's one piece of the intrusive symptoms. The anger, that's one piece of the mood symptoms. The mistrust, that's a moral injury potentially. That's one piece of the mood symptoms. He avoids medical care. That's the avoidance criteria. Nightmares, that's another intrusive symptom. Always on alert, that's the hypervigilance. That's the fourth symptom category. I won't go through all of these. The not believing in God anymore is potentially moral injury. So that's another piece of the third criteria. People don't play by the rules. That can be a piece of the mistrust. That can be part of moral injury. So, I mean, this was sort of this is a hypothetical case. It has pretty much every imaginable PTSD symptom you can have, but it's just to highlight for you the diagnostic criteria. And so in this question, if we had like a button or something people can answer, but after providing like supportive therapy and sort of counseling him on what, these are the therapies that are the primary recommendation, he tells you he doesn't want the therapy, then what would you say is the most evidence-based approach? So I'll just go through each of these. So one would be start Ativan, which is a benzodiazepine for sleep and irritability, and do a chaplain consult. No, remember we talked about Ativan is not a great choice in somebody with PTSD, so that's not the answer. B, recommend prazosin as the primary treatment. Start citalopram. So that wouldn't be a primary treatment. Really, prazosin is not a first-line medicine for people. C, recommend follow-up psychotherapy as the primary treatment. Start Zoloft daily and prazosin for nightmares and do a chaplain consult. That's actually the correct answer. So that's following the evidence-based recommendations. And the last two are doing other medical interventions that really wouldn't be evidence recommended. So you shouldn't be recommending those first. And also, but number E though, recommend follow-up psychotherapy as the only way to improve his symptoms. So that's not correct either, because that's not true. So even though I really highlighted how helpful psychotherapy is, that's not the only way to get better from therapy or from PTSD. Okay, just a summary of the things we talk about. So in PTSD, the takeaways, the 5 primary things are: 1, the exposure to trauma; 2, the re-experiencing symptoms; the avoidance symptoms; the negative thoughts; and the arousal and reactivity. Moral injury can be a big piece of PTSD, and actually there's some studies that show it might correlate with increased suicide risk. And I didn't mention this, but chaplains actually are very helpful in people with moral injury. So that's why that was listed as an option here to help them, is because chaplains can be very helpful, especially in our case, and the guy who doesn't believe in God anymore, maybe wants to process through some of those things. These are the therapies that are the primarily recommended. I won't reread them. You can use medicines to reduce things like nightmares, to help with sleep, to help with the mood symptoms. And the primary big medicines are Zoloft, Prozac, Paxil, and Effexor are the best choices. Please avoid benzodiazepines in people with PTSD. So that is that's the talk about PTSD, evidence-based treatments for PTSD. These are all the, if you ever want to look up the actual studies and references. And with that, I'll turn it back over to open up for questions from people that people have.
Excellent. Thank you so much. Yes, please. If you have any additional questions in the chat, or any questions, feel free to put them in the chat. I have a few questions myself, because I just loved the presentation, and I was just really excited that we're talking about kind of all the different types of opportunities for people with PTSD to experience some sort of treatment. Like you had mentioned, there's really no one way, and it's almost like trial and error sometimes when it comes to helping people with post-traumatic stress disorder. And because there's such an overlap with traumatic brain injury or TBI, it can be hard to diffuse which is which, but really looking at what are the symptoms and how can we treat those, and kind of go from there. One thing that I was thinking while you were talking, some people experience, when they experience a traumatic brain injury or TBI, they don't necessarily remember the event, whether or not it's, self protection or memory challenges and gaps from the actual brain injury. How does that, if any, are you seeing in terms of research or personal experience, impact the development of post-traumatic stress disorder, if at all?
That's a great question. So how does not remembering the event impact the development of PTSD? That's interesting. And thinking about like how PTSD works, if you fully don't remember it, it's almost hard for me to imagine how you would develop PTSD, because so much of PTSD involves the memory of it. Like the avoidance piece, for example, when you really dive deep in therapy with these folks, really what you're trying to do is to have them challenge their thoughts about the memory of the event. And so, like, have you seen people with PTSD who don't remember anything about the event? That's a question I asked back to you, I guess.
Yeah, I mean, there's definitely some elements of PTSD that sometimes I see, but it is less common. And so that was going to be my follow-up, was like, how would you treat someone with that? If anyone in the listening has had that experience, feel free to put it in the chat. But it was something that I could see, maybe if there's like kind of subconsciously or unconsciously, they're like still kind of got those like sort of like, jitters, or maybe
Yeah.
they, hearing a car boom or something like that and still being really startled by it, but not necessarily being able to recall that incident. I would imagine therapy would be really challenging to challenge those thoughts.
I got what you're saying. And so there could theoretically be somebody who like suppresses it, for example. And so maybe I was thinking more like if you were in a blast injury where you had such a severe injury that you don't have any memory from a medical injury to your brain from what happened. But like sometimes people could like suppress them potentially, I guess. So maybe you had a trauma happen that was so traumatic that you've pushed it out of your memory. I just am careful with that because in the early 90s, this was a big thing where the whole people may have seen on the news and stuff, suppressed memories about like, rape or sexual assault and things like that. I personally am very careful with that because there is some evidence to suggest that we actually can traumatize people by doing that, by putting ideas into their head that actually didn't happen or that were not there. That was a lot of the criticism in the early 90s. And so I'm very careful to like bring up the idea of trauma if the person doesn't remember a trauma, because I don't want to be putting an idea of something that happened in their head that did not happen. And so I guess I don't see that coming up a whole lot in the patients that I see. Most people would remember the things, and that would be what you'd really be focusing on, because a little bit to your point, if they don't remember what happened, it's going to be hard to know what to work on in therapy. And so I would also be digging to make sure that PTSD is the correct diagnosis. So that's my job as a psychiatrist, is to really dig down deep, look through these criteria, the criteria of other disorders, because maybe they have a personality disorder, or maybe they have major depression or a different disorder that's not PTSD that has a potentially different treatment. And so I think if people out there, any people are having trouble figuring out, they don't remember things, it's not PTSD, always have a low threshold to ask for help. I do that myself. None of us know everything. And so trying to get this person for a second opinion, to get them to see, maybe an expert on these disorders can be very helpful. All right, it says, do you see mindfulness practice such as meditation, yoga, Tai Chi, Qigong, I'm not sure I'm saying it right, becoming a part of treatment recommendation? Yes, absolutely. So I didn't mention these therapies in the evidence-based therapies, but there are actually pretty good amount of studies on things like mindfulness, yoga. There's a type of therapy called, I'm blanking on the name of it now, which is basically a structured therapy that uses mindfulness meditation kind of stuff. I think it's called present-centered therapy, that show actually great benefit in people with PTSD. And these are great approaches for somebody who, there are a lot of vets who tell you, like, I'm not doing a therapy where I have to talk about the trauma. Like, no way, I'm not talking about it. And all those therapies I just mentioned were those kinds of therapies. So you basically would have nothing to offer them. But that's not the case, because these therapies that Cynthia Haas mentioned have been proven to help people as well. And that's actually much of the argument for these therapies, is that they're great places to refer people if the person is just adamant that they don't want to talk about the trauma. And so we know that things like mindfulness, yoga, the approaches she mentioned here, they can help reduce some of the hypervigilance that we talked about. They help reduce the sympathetic nervous response. And so at HopeWay, we have regular meditation every single day. We have yoga several days a week for the veterans. And the reason we use those is because we know they work in people. And so I think they're just not listed in the VA recommendations for the same reason the outdoor therapy is not. There's not enough evidence yet to prove they're helpful. Although my suspicion from working with people is that that will be proven. It's just we don't have it yet. And so I am all about them. Also, my approach with them is they don't hurt anything. Like anything the person comes and tells me, if they think it helps them, if it's not hurting anything and it's not illegal, then we want to get them doing that. And so I think these are great options.
Dr. Johnson, there was a question earlier about if you were seeing new patients.
Yes, definitely I'm seeing new veterans at HopeWay or non-vets. I also see non-vets as well. You can reach out to me. Sometimes it's easier to reach out to Karen. If you want to reach out to me, my email is just my name, justin.johnson@hopeway.org, or Karen, or I can give, Karen, have you put like the admissions number in here?
I will do that. In fact, I was just typing in our information about our outpatient clinic. If someone would want to see you individually outside just individual sessions. So I'll put all that. Oh, there you go.
Yeah.
I'll put the HWPA number in there too.
Good. Now I do see outpatients. Give us a call if you're interested in that. Just to be upfront about that, the outpatient clinic I have is a very small clinic, and they don't take health insurance there. But give us a call. We can see if we can work something out. But we do take the insurance and the VA referrals through the HopeWay main program that we've talked about. So some ways that might be the best way if you have a person who's interested. But good questions. Other questions for people? But I'm also happy if people, even if you don't have a person refer, if you just want like a curbside question or like, what are your thoughts on this person? My primary interest is this kind of stuff. And so I'm always interested in talking about it. Other question I think somebody was fixing to ask.
Yeah, and I put I redid the number in the chat, so you guys can see it, because I think Dr. Johnson, you had just done it to hosts and panelists. So just I put that again if you say it again.
Just that for the private pay clinic, my outpatient clinic, many insurance companies will reimburse people. So if you know somebody who wants to come see me, it is private pay, which means they have to pay like you're going to get a massage or something. But then their insurance will often reimburse you for it anyway.
And I might add too, I know our audience has from a lot of different backgrounds, but part of my role too is to help try to connect people to the right resources. So if it's not necessarily HopeWay, I know a fair amount of therapists in communities, not only in North and South Carolina, but really all over the whole country. So I can also help people with recommendations there as well. If you wanted to reach out for that, I'd be happy to help you.
Wonderful resources, that's for sure. I had a quick question about the relationship of maybe like opioids and veterans, and kind of looking at, previously we saw a lot of medical doctors prescribing opioids for pain and other types of things. Do you still see a lot of individuals, coming with maybe either addiction to opioids, or what's the kind of relationship with that in terms of either self-medicating PTSD symptoms, or maybe looking at that relationship with TBI and pain?
Yeah, great question. Obviously, the opioid epidemic has been a big problem beyond just veterans, so for Americans generally, but especially in these vets, many of whom have TBI, develop chronic pain. Unfortunately, many of them were put on opiates and became dependent on them, addicted to them. Now, I think in medicine, like among medical prescribers, doctors, it's much tighter now. Many fewer people are prescribing opioids, especially for chronic pain, not just because of the addiction potential, but because, again, following the evidence does not support opioids for chronic pain. Opioids are best used for acute pain, which are things like if I broke my leg, or if you have your appendix removed. That's why it's called acute pain. There's a very specific cause that's going to go away with time. So opiates are really not a good choice. And so there aren't many people prescribing from what I see. But, unfortunately, it's common. And it actually, interestingly, if you read, earlier I talked about reading like histories of various combat people, and there are lots of descriptions of Civil War soldiers who were addicted to opioids, so opium. So it's before things like heroin were invented, but they did have opium, which is an opiate, and they sounded exactly like the people we see today. And this was in 1865. I think Edgar Allan Poe was addicted to opium and died from an overdose, and he was also a veteran. And so these aren't new problems. They're problems that have been around as long as humans have been traumatized, unfortunately. Another interesting idea is many people do use them. You asked this, to reduce symptoms, basically to numb themselves out. And cannabis as well, marijuana, it's pretty common. People abuse that for the same reason.
Yeah, very, very interesting to see that kind of like that connection with opioids, and as you said, it's a problem that many people experience.
Yeah, when you see people, you'll get people where they become almost suicidal, where if they have such severe PTSD that they don't care about living anymore, and every time when they take the heroin, for example, it numbs them out, they could get to the point where they could say, I don't care if I just die from this overdose, and kill themselves. And so that's the danger of opioids in particular, is they're very lethal potentially.
Yeah, you mentioned one of my questions was related to kind of, we have this unfortunately really high rate of veteran suicide throughout the country. Is there a relationship with post-traumatic stress disorder, and are there any sort of specific resources that you recommend for people that might be in that kind of crisis mode with a mental health crisis?
Yes. So I think from my personal experience, yes, there is a correlation. People with PTSD, when you develop these kinds of moral injuries, like I talked about, and it leads to depression. Very commonly, people with PTSD also have depression or major depressive disorder, which correlates with suicidal thinking. So definitely think there is a correlation. And so anyone who's in a crisis, you always want to get them to immediate help. So the most immediate would be calling 911, taking them to an emergency room, making sure they get to an emergency room setting or get to EMS to take them to an emergency room. That's the safest way to make sure they're safe in a crisis. Beyond that, the VA has a suicide hotline that people can call. If they're a little more stable, that's where places like HopeWay could help. Trying to get them into a longer term treatment center like HopeWay can be very helpful. That's a big part of our goal. We've been open for a year and a half, and we haven't calculated yet, but most of the people had reduced suicidal ideation from treatment here. So that's a big part of our goal. And there are a lot of other organizations who are really trying to reduce this. I mean, it's a national problem.
Yeah, those are.
Thank you.
Sorry, go ahead. What would you say again?
Just responding, I see various people leaving. Thank y'all for coming. That was awesome.
Yeah, thank you. I just have a few more questions.
Sure.
I'll probably keep you till 1:30. I enjoy your input and just having this kind of discussion time.
Yeah.
But so one thing that I was thinking about, at HopeWay, it sounds like you have situations where you might have like either maybe group therapies or multiple people with kind of different challenges, different experiences, different diagnoses, all in a group or shared spaces. And we see that a lot with, some services targeted for individuals with brain injury. You have a lot of different people with a lot of different challenges. Are there specific ways that you can accommodate for PTSD or trauma, big T trauma, in kind of groups to be able to prevent triggers? Or how can you best accommodate for like all of those different challenges that they might be experiencing, and particularly with PTSD in groups?
In the group setting. So I should say I don't run the groups myself. So
yeah.
I'm not the biggest group expert, although I have run groups before, but at HopeWay I don't. So I think you just generally try to, you let people know, at HopeWay we always ask people to say like this could be, triggering to somebody, and so to give them like a warning beforehand. If they're going to talk about, for example, being blown up in Iraq, to say that beforehand, like this is going to be talking about some disturbing stuff, so people could leave if they feel like they need to. But otherwise, it's just balancing the group, making sure not one person, dominates the whole time, and making sure it's a comforting, welcoming place for people to feel comfortable sharing things. Those are the general approaches. But the other interesting thing about it is that when you're really trying to treat PTSD, you want to try to get rid of that avoidance piece. And so what you really want to try to do is to help the person be able to tolerate hearing things like that, because that often is part of the problem. Is that with PTSD, you're maintaining avoidance. So, for example, if let's say I was raped by somebody, and that let's say I was raped by a man, and now I avoid men, and particularly men who look like or remind me of the person who raped me. And every time I go to group, I can't tolerate hearing this man in my group talk. I leave. That's dysfunctional for me. It actually is helpful for me to be able to tolerate being around this person, because this person's not the rapist. This person has nothing to do with the rapist. I am totally rearranging my life in a dysfunctional way that's not helpful. So I think part of our goal is actually to help the people tolerate the potential triggers, because that is how you get better from PTSD, is when you no longer have to rearrange your life because of the traumatic thing that happened. But that's a process. And so that doesn't necessarily always happen in the group setting. It happens with a lot of work individually usually. But it's why, I think we have very skilled therapists who run the groups here at HopeWay that I think do a very good job of that.
Yeah, I feel like one of the things also I've heard is, a lot of veterans might not want to have their back to the door,
Yeah.
and be able to see an exit. Where might that fall into that? Is it because it doesn't necessarily harm their participation? It's sort of okay, or where do you see that sort of
Yeah. Well,
fitting
the
in?
same thing. We would want to work with the veteran. The goal would be to where they don't have to do that, because that could be causing them problems. Like, let's say you go out to eat and the only table available is the one, by that doesn't have that facing direction, and then you leave. Well, now you've like rearranged your life for something that's dysfunctional, like that's not based in reality. So our goal is to help where they don't have to be that way, but you can't force people to do that. So you're going to work with people where they are. But if you're a skilled therapist, that should always be your goal, is to help the people live a more full life. So that the scenario would be that person would probably start out in the groups sitting where they could see the door, vigilant, and gradually over the 4 to 6 weeks they're here, they'd sit anywhere, hopefully, and feel calm about it, feel comfortable, not feel vigilant. That would be the goal.
Mm-hmm. Yeah, because I would imagine there's, with that constant hypervigilance, there's this sort of, constant stress response, and that stress response could significantly lead to fatigue more easily, maybe chronic conditions, chronic health conditions with your heart, with your, just sort of your entire body. So you think it's not necessarily a big deal. No, I just need to see the door, but it's actually, you're at a physical state that maybe you don't even recognize.
Great point. And there actually is more evidence coming out now showing that people with PTSD have higher rates of cortisol, which is a steroid stress response hormone that all of us produce. That basically, just like you said, it's not healthy to be living in a chronic state of high anxiety and stress. So absolutely. And that's also where things like the meditation and mindfulness can help reduce a lot of that.
Absolutely, absolutely. One thing that I hear often in, in veteran spaces, military spaces, is kind of a lack of trust with civilian community providers and things like that. How can you see that? How can civilian supports be more helpful to the veteran and military population if they're experiencing PTSD, so that it's not necessarily a harmful experience?
Yeah. So in general, I think the first thing is just being curious. So being curious and empathic. So, exploring, tell me about your experience, just being honest and upfront too. So, you can say, I'm not in the military. I've never been in the military. I don't know. Help me understand your experience. That's just true for anything in mental health, I guess. None of us know with 100% the experiences of the other person. So I think that's the best approach. Some people appreciate, saying things like, thank you for your service, although many people don't. They see that as like overdone and not genuine. So I think it's just being curious is the best thing you can do.
Excellent. One thing, so you're seeing individuals from all walks of life. Do you find that there is a history of maybe either a lack of belief or lack of kind of buy-in that people have experienced from medical professionals, because PTS symptoms aren't necessarily something that you can like put you can't like, do a medical scan. You can't see it.
Yeah.
It's not concrete. And so I know some of the feedback that we receive is, oh, well, no one really believed me, or they didn't necessarily want to deal with it. Or maybe they, received it in a situation that isn't necessarily recognized as, harmful by the big powers that be. So, is there, do you find that lack of belief from the people that you serve? And is there something that we can do to try and overcome that?
Yeah, I mean, I think it's an interesting and a good observation. I think that does happen out in the world. I mean, I think here at HopeWay, we don't have them, and we believe people and we're trying to help them. But it is true. I mean, these disorders, both TBI, unless you have a severe TBI where you have like an obvious neurological injury or something shows up on the brain scan, things like concussion or mild TBI and PTSD, you often don't see the things necessarily, although generally you can. So what I try to do is just we observe people over time, and if you consistently see it, then it's most likely is legitimate. But yes, we definitely do that. So I think, in terms of ways to reduce that, I'm not totally sure. I think just trying your best to believe the person and to, but me as a doctor, I'm always trying to think like, is this the accurate diagnosis? So I actually am always questioning. Like my initial response is to wonder, like, do they have this or do they have something else? Because that's my job, is to definitively prove as best I can, almost like a judge would be. Like a judge would go into a case not assuming that something is the case. They would want to hear the evidence for it. So that's what I do, because it is true that there are veterans who are maybe making this stuff up potentially. That does happen, particularly when you can get long-term disability benefits for things. And so I don't think it's totally unfounded that some people question it, because it does happen. I saw that frequently at the VA. So I don't really know the best way. I think part of it is just continuing to educate people and to be open and observing and curious about the person and try to think critically about it. That's what I try to do.
Excellent.
So this may be a little different answer than you were expecting. So I do not go with the assumption of I'm just going to believe everything they tell me.
No, I think that's important though too, because there's so much kind of not concrete evidence. It's important to also
concrete evidence. There is some. I mean, big part of my job as a psychiatrist is to observe their behavior when they don't know I'm observing their behavior. That's a lot of what we do at HopeWay. It's called the milieu, like you do on an inpatient unit. We're observing these people's behavior 24/7 by a variety of staff members. And it helps with, it's called diagnostic clarification. So it helps us get a picture. So for example, if there was a person who came in and said, I have PTSD, and maybe they're saying their primary focus is, I've got PTSD, and they keep asking me, will you fill out the paperwork to get my disability payments? Will you fill out the paperwork to get my disability payments? And they say they have like depression and they can't sleep, but the nurses see that they actually sleep every night, and that they seem very happy and are joking with people and don't seem distressed by anything. And they keep asking me about the disability payments. That could go down a path of me saying, I don't think they have PTSD. Like this is what's called malingering. And so that actually is an important part of what we do at a place like HopeWay, is we can help, people like y'all, community people, get a full diagnostic picture of what actually is going on with this person. And sometimes the conclusion is that they don't have it.
Gotcha. Yeah, I think that's a really important point to make. This is just something I haven't read anything necessarily about it. So if it's if it's a weird question, I'll just take that as it is. But do you find that veterans with post-traumatic stress disorder, or PTSD, lead to greater chances of family members potentially creating having a cycle of post-traumatic stress disorder if they're put in those kind of traumatic situations, as the veteran member with post-traumatic stress disorder is like experiencing a flashback or triggered in some sort of way, and then the family member kind of is in between that? Do we see a cycle of post-traumatic stress disorder, or is that something that maybe we'll see in future generations with long-term studies?
Yes, absolutely. So definitely people who've been traumatized, doesn't just true for combat vets, but people who've been traumatized can tend to repeat traumatic things. So Freud called it the repetition compulsion. Combat vets in particular will have this anger and this irritability. And these are people who've been trained in violence. So they've been trained to shoot and to fight and to hurt people. And so, especially if you combine it with like alcohol and things, it could lead to violence. So to lead to continuing to re-traumatize. And I know that's a concept that I'm not an expert in, but people talk about it as like generational trauma, where it basically gets repeated over and over. And you learn as a kid that you get, beaten and assaulted, and you grow up and you do it yourself. That definitely happens. I'm actually reading, I actually have it right here. This is a fiction book, but it's called The Great Alone by Kristen Hanna. It's an incredible, I'm only about halfway through now. You can barely put it down. She's just a great writer. Totally a fiction book, but the primary character in it, is the daughter of a Vietnam veteran. And I think he displays perfectly like what I'm trying to describe. I mean, he comes back and he becomes paranoid and agitated and violent, and then he traumatizes the people around him. So I definitely think that can happen. And just a side note, this book is great, so I recommend it to people if you like to read.
Excellent. Yeah, I think that getting supports for family members, for children, for parents, is just as important as supports for veterans. So I think that's why I was glad to mention that, or to ask about that.
And you have to make sure those people are safe too. I mean, particularly if it's children,
Yeah.
an obligation. If you have a person who's potentially violent or something, that's we have to pay attention to that.
Yeah, definitely. So, and then I just have two more questions or so. With the 4th of July holiday coming up, we know that there's a lot of fireworks and potential triggers for individuals with post-traumatic stress disorder. Do you have any kind of at-home tips for people that are experiencing, post-traumatic stress that they can kind of take home with them today to be able to maybe make this holiday a little bit more safer and less triggering?
Yeah, I think, I think, um, I don't, first of all, things like saying safer. As a PTSD expert, we want to be careful with that because we want to remind these vets they are safe. Like they're not.
That's true.
Fireworks are not unsafe. So we don't want to reinforce this idea that the world is unsafe because that's actually what maintains the PTSD. We actually want to reinforce the idea that it is safe. So I try to not use those types of words in that kind of scenario. So maybe to make it less distressful to them. So that's what I would say. So they're not as stressed by it. I don't know if there's things that we can do particular because, the rest of the world has to keep living. So I think, there's going to be fireworks are going to continue happening. I guess if there's a veteran who lives next door or something and that they could just maybe check in with them and ask, hey, we're going to be doing fireworks. So to let them know, it's basically like a trigger warning, something would be. So to say, like, we want to let you know we might be doing fireworks, but we can totally hold off if it bothers you. So they're aware of it. That's the biggest thing. Otherwise, like societally, like if you're not know of any specific veterans, I don't know what you would do because I don't know if you know that they're around or not being upset by it.
Yeah, I think I'm glad you mentioned the safer comment, and hopefully I think the trigger warning is a really good thought. We just have some things in the chat. Just gonna ask a question. As my father was violent and acted things out, hallucinations that occurred in Vietnam, so something very similar to what we were mentioning.
Yeah.
And so thank you for sharing your story there. But the last question I have, and I know we're just a little bit over time, but is there a gap that you see when we're treating individuals with post-traumatic stress disorder or community agencies that advocacy organizations such as the Brain Injury Association of North Carolina can help with, or how can we better support individuals? Where do we take this information?
Yeah, that's a great question. I think all of us to continue to do the work you do, taking care of people with traumatic brain injury, I'm sure you have an enormous veteran population. So to continue doing the things you have expertise in that I don't even know about all those details. You have much more expertise than me in many of those areas. So continuing to do that work, I think would be the big first place to start, to try to make sure people are aware that there are ways to help them feel to get better so that we know. So like if you have a vet, who, let's say we use that example, the neighbor who, says, you can't do the fireworks. We want to help that person to be more functional. So to bring up, have you heard about, if you're ever interested, you let me know. I know of these programs at the VA and at HopeWay, and I know there's ways to help people feel better to where you can come enjoy the fireworks with me. So to like always offer the options to people to make sure they're not, that they're aware of them in case they're not. To reduce the stigma, I guess, to continue, highlighting that these are real disorders. They're real disorders. We know they are because we see people every day who are suffering from them, but also highlight that people will get better. And so they're not they don't have to be permanently disabling. People can get better from them if we do the correct treatment for it. Those would be the big things I'd say.
Excellent. Thank you so much. I really appreciate your time, your knowledge, the discussion that we've had, and just kind of continuing your education about, post-traumatic stress disorder. I encourage everyone out there to check out HopeWay, and learn more about what they have to offer. I'm going to put the certificate link in the chat. It'll also be in your follow-up email as well. I also wanted to put in a link for our Making Connections podcast. And we just did, at the beginning of this month, we have 3 episodes talking to service members that I've used service animals to help with mental health challenges and post-traumatic stress disorders. And it was, they're really wonderful conversations I encourage you guys to take a look at. And then the last thing I'm going to put in the chat is are some dates that I had mentioned at the very start. And I think that is it. I don't see any additional questions. Thank you guys so much again. And, you know, everyone be on the lookout for the recording and presentation slides on our website coming soon. Thanks so much, you guys. Have a wonderful day.
Thank you, Lauren. Thank you, everybody.